I have a background here that's stated here, and that's our clinic on the corner of 25th and M. I really lucked out with this location, and those of you who've been there know it's a really lovely facility, and I was very fortunate to get that. We're doing exclusively stealth pathogen illness or related tick-borne illness, whatever you want to call it. And I had lots of help for today's talk. Dr. Umabu is my physician researcher. Mr. Sweeney is a consultant. And here are my PAs, and some of you know these names, Kelly to Kimberly, Tara Fox, Rachel. This is my wonderful special assistant, had constant dialogue with Claire. And other, PJ Langhoff, I don't know if anyone knows PJ, but she's a prodigious author and intellect and savant. I call her savant in the Wisconsin woods. This is something, I like to make quotes. I like to create little quotes, and then I like to borrow quotes from famous people. That makes sense because I think they have a way of putting a foundation on things. So what I say here is what I've learned in practice has been from patients, and that's how medicine works. And I think that's been one of the reasons we're going to talk later briefly about, okay, what happened? How come we have this epidemic now? Why now? Why so ugly? Why so unrecognized? What happened? And what are the confluences here? So we've had a perfect storm. One of the things that's happened is doctors stop listening to patients. You know, they talk at patients. So you can't learn. You might as well do something else. And so I say a little prayer before we talk, and I really feel this, and I'm so very despondent about what's happened to the practice of medicine, the profession of medicine. It's really disheartening to me. It's a unique privilege to participate in a patient's care, and we should remember that. You know, not everybody gets that gift, and it's a gift that's being squandered, in my view. And the good physician has humility. It's more important to know what you don't know than what you know, and you should be humble about it, and you have curiosity, abiding respect for the complexity of the human condition. These are things I live by, and you know, I just, when I see a patient, I just try to identify with that patient what they're suffering with, what they're suffering from, what they don't understand. And so here's an outline of today's first talk. So I'm going to try to get a definition. I have for 10 years tried to bestow a definition on ILATs, and they've ignored me for 10 years. But I do have a definition, a working definition. We're going to talk about persistence, pathogenicity, what makes this thing go, how to evaluate the patient, and then we're going to look at some of the neurology that's associated with this. First of all, there's no accepted definition. It's incredible. What is Lyme disease? Well, you know, where's Waldo? I mean, here's my definition, or one of them. It's chronic relapsing, otherwise unexplained encephalopathies. There are three pillars: encephalopathy, arthritic symptoms, or periarticular symptoms, and neuropathic symptoms associated with tick-borne infections spearheaded by Borrelia burgdorferi in combination with co-infecting organisms. So complex is a more appropriate term than persistent Lyme disease, because it is a complex of infections, and it's a compendium, if you will. So again, as we go through this, these are our pillars. So virtually every patient will have these, and if you do a filter with these three categories, and you go down through all known diseases, this disease, as defined, floats right to the top. So you have encephalopathy, which is a vague term, but mentation, mood, sleep, head pressure, head pain, periarticular symptoms or frank arthritis, unexplained, and sensory symptoms, so that you're having numbness or burning or unexplained, or stabbing pain or weakness, or all the above. There are dozens and dozens and dozens of other symptoms. And this is a very complex illness because it infects, we have multiple infecting pathogens. We have a multisystemic disease. In other words, every system in the body is at risk. We have multi-compartmental neurologic disease. So now I know the brain is all connected and woven and networked and all of that. I get that, but for the basis of following and for definitions, we take each part of the brain and we look at that and what its function is and what disease, how the disease is affecting it, and that way we can track it. And I can tell you that every single part of the brain is vulnerable. Every part of the brain stem, every part of the spinal cord, and every radicular tract that comes off the spinal cord is in play. So you can have an immensely complex neurologic picture. So it behooves you to touch the patient because you'll find things. Now, our spirochete. Here's all life form, the phylogenetic tree of life. We have the eukaryota here, which are nucleated multicellular animals and plants and so forth. We have our bacteria here. The spirochete chain is really the king of the group, and it stands out. It's unlike other bacteria. It's gram-negative rods, gram-positive cocci, and so forth and so on. It is different, distinct. It has more genetic armor, if you will, and can cause relapsing disease. We have our domain, phylum, class, and we go down here through the spirochetia, and then we have Lyme disease. We have early recurrence, which is relapsing fever. We have lone stari causing stari, and then over here we have syphilis under this branch in this genus, and leptospirosis. So this all comes under complex Borrelia sensulata. It's a collective term for all Borrelia species known to cause Lyme. Sensu stricta is the predominant species in North America. We also have Azeli and Garnier, traditionally stated to be here in Europe, but trust me, there's strains across the pond, back and forth. And friends of mine have found new species like Americana, carolinensis, easy for me to say. So they're finding new species, and then everybody's probably familiar with Myomote, which the wizards at the CDC will say, oh, we found a new spirochete. That's what's going on with everybody. We're brand new. And I say poppycock. And you probably think I'm just playing to the audience saying poppycock, but I'm not. I actually say that word. In fact, I said that to my lawyers a couple years ago because I was mad at them about not doing something or charging me for something or whatever. That's not important. I was mad. And I said poppycock, and they said, they didn't know what the word meant. They thought I was making some vulgar remark. And so the next day, one of my lawyers, Jacques, said, called me, Joe, I read poppycock. Just bullshit. Just means bullshit. I said, right, Jacques. Yeah, this is the guy I pay till I bleed. I said, right, Jacques. It's English for bullshit. This is a famous man. This is Dr. James Oliver, his protege, Dr. Kerry Clark. Believe it or not, this is Georgia Southern, and he has done more investigative research in the epidemiology of ticks and Borrelia burgdorferi than anyone. And these were colleagues of mine that went down there. This was 2004. And now we have a comparison between Borrelia burgdorferi and our friend syphilis. So comparisons, we have chromosomal, we have 21 plasmids in the cytoplasm. We have 132 lipoprotein genes, which really deal with survivability. More genetic material. 90% of the genes in this bacteria are unrelated to any other genes known. And it's linear DNA, which is unusual in nature. So we call syphilis can only live in us, the human, whereas our friend Borrelia can live in any arachnid, small or large mammal, fowl, anything. So we call syphilis Lyme's dumb cousin. Very good. Most people, I'll go through this quickly, familiar with the life forms. So when we're dealing with the spirochete, it's very capable of being chameleon-like. It can be the wild-type spirochete form. It can have blebs and vesicles, which is just portions of DNA thrown out, but the immune system can't tell the difference. L form, cell wall free. And of course our cis form, which is glycoprotein wrapped, pretty much inert and not recognized by the immune system. These things can live in the cell, out of the cell, and all fluids. It's been isolated from just about everywhere. So very, very versatile organism, to say the least. This is a study done in 2006 by Dr. Livingood at the NIH in the vector-borne section in Fort Collins, Colorado. And she said that she did a monolayer of all the neural cells and then overlaid it with B31, which is a laboratory strain of Borrelia. And all the cells that was invaded, the Borrelia B31 invaded. In other words, it dug into each and every type of neuron. This is kind of frightening. And she surmises that infection can result in serious, acute, and late-term disorders, a degenerative condition of the peripheral and central. They wrote this 10 years ago, and they're still in denial. I mean, there's such a disconnect here. And then invasion of neural cells provides putative mechanisms to avoid host immune response, causing functional damage, et cetera, et cetera. So we have shown that it can invade any cell. I've already made reference to the fact it can invade any compartment. All right, when we talk about brain tissue, look at all the things that happen here. In fits and starts, it can be fairly dramatic. All right, so how does it evade the immune system? Just very quickly, there's active immune suppression, there's immune evasion. I think Judy knows a whole lot more about this than I do. Physical seclusion in privileged sites. And there have been over 70 papers in a period of 20-some years which demonstrate persistence of Borrelia in animal and human models. So we have plenty of data. There's always been plenty of data. I was going to say here that the difference between Borrelia, and there's a very good article about comparing syphilis and Borrelia. It's actually excellent. It goes through it, and they both lack the lipopolysaccharide. What's different about them is that they have lipoprotein. Lipoprotein is antigenically much more provocative to the immune system than teichoic acid in gram-positive bacteria or lipopolysaccharide in gram-negative bacteria. So the lipoprotein has the ability to attack all sorts of mammalian programs, integrins, cell wall sugars, amino sugars, and invade, and it's a maniacal response, hyperreactive, and this is Dr. Herxheimer. He and Jarish discovered the Herxheimer reaction in syphilis, in syphilitic patients back in the late 1800s. This is my daughter, Jordan, who survived cancer, and I said, honey, can you do a cartoon for me? And I'm trying to think of something that's really mean and it's got fat in it and protein. And, and so she came up with the fat fly meanie. And which was really cool, I thought. All right, oh, look out. Oh my. So they took the name Herxheimer, the name Herxheimer came from these guys who observed that with the secondary form of syphilis, when they treated with antimonials or mercury, whatever they treated with, these lesions would fester and swell and rise up and become volcanic, and they'd have febrile reactions, and then they would get better and go away. And they call that the Herxheimer reaction. It's very predictable. We have the Herxheimer reaction with Borrelia. The problem with Borrelia is it's in the brain. Do you see the problem? It's in the brain. Now, this is really important that as virulent and evasive as Borrelia is, it does not act alone. It has never acted alone. And so years ago, it became clear to me that there were co-infections that were very important, and now I think they're actually the engine. So they facilitate the expression of the spirochete, block the immune response, allow the spirochete to go drill where it wants to. And some of the other co-infections like Bartonella just follow right behind, which is a gram-negative intracellular obligate aerobe, and just go right behind and drill as well into the same neural cells and so forth. And they love blood vessels in particular. So you have to sort of drill down and get the idea that, and think about the axon and the sheath being actually infected. That small fiber is actually infected. And think about it that way and it starts to make a little more sense. So when we see a patient sick enough to have any loss of quality of life and debilitate anyway, we know, we don't even test, and if the physical findings aren't there, like hepatosplenomegaly, it doesn't matter. You know, years ago I said, well, they don't have Babesia, I won't treat it, and I always got bit in the butt, you know, because it'd come back with big spleen and, you know, Babesia. So I stopped doing that. So I treat everybody for, so when we address a new patient, we're addressing several co-infections, and there are probably another dozen behind that. But the point is, if you put your house in order by knocking out these major pathogens, the immune system will reset in most cases. All right, so here's some working concepts. Ticks are capable of transmitting all Borrelia species. I think it's akin to the HIV story in that there were always more efficient ways to transmit HIV. I think the tick is the most efficient way to transmit Borrelia. I don't know if horseflies do it. I don't know if mosquitoes do it. I don't know. I don't know if sandflies do it. I think sandflies transmit Bartonella for sure. I don't know, but ticks are clearly more efficient. And I've said that there. They harbor, lots of stuff, and more than one pathogen may be transmitted, but the way it really works is that we pick these things up one at a time, almost always. So as a child, we pick up a Borrelia species of some kind, and then later on, we have Bartonella from the animals, or maybe human to human. We all have mycoplasma species in us. We all have Chlamydia pneumoniae species in us. They become opportunistic. So this disease, as Judy has alluded to, I'm sure, is acquired immune deficiency. It's not like AIDS. It doesn't have the orderly progress. It's not quite as brutal, but it is very bad. And it will affect your cell counts and compromise you. The immune system becomes fatigued and very dysfunctional. And I do think that because it is a super spirochete, it's sexually transmitted. I mean, that's not a big cognitive leap in my mind. And I know we have families here we have patients here where the whole family's infected, and that we must have 200 families. Mom and dad are infected, one or the other, both. Two kids, 3 kids infected. So it's either common source or it's vertical, et cetera, et cetera. And of course, our government will not even think about that. They want to cause a panic, I suppose. And the lie is too big to confess at this point. So somebody's head's going to roll, but it's not going to be on their watch, right? So there's not a single study about sexual transmission, not one. They're afraid of it. And so I always say between sex and ticks, everybody's got the spirochete. And okay, biofilm, which Alan was going to talk about. So biofilm is a polysaccharide moiety, which is generated by virtually all manner of microorganism. It's important to realize that Borrelia doesn't have its own biofilm. It's a jelly castle, I call it, full of tunnels and exit strategies and that sort of thing. But the bacteria go dormant. Fungi live in there, so it's a menagerie. It's not just we don't have a Borrelia biofilm. We don't have a Candida biofilm. So they're all together, living symbiotically, I suppose. And it's everywhere in nature. Any type of chronic infection is associated with biofilm. They survive very nicely, and then the problem is antibiotics and the immune system can't get to them. There are some nuances to that. So for the last 3-4 years or more, we've been employing a biofilm technique which is really effective and simple, and I'll get to that in a little bit, but I think you have to do that. You have to employ biofilm. The major errors I see in treatment of this complex condition is not getting adequate treatment for babesiosis and not addressing biofilm. And biofilm exists, babesia exists in biofilm. And I'll tell you how I know that. 2 or 3 years ago, I decided to try xylitol, which is a synthetic sugar alcohol, just as stevia is a natural sugar alcohol from the stevia plant. As a sugar alcohol, it acts as a detergent on polysaccharide. So it basically scrubs it out, reduces the pathogens to become planktonic or free-living, are much easier to kill by 100-fold, 1,000-fold, what have you. You have to kill what comes out of the biofilm. You can't just release stuff and So xylitol and lactoferrin were being used by a Montana group for wound infections. And I looked at it and I didn't think too much of it, and I didn't give it much hope because I really was disillusioned with serrapeptidase and Beluca and nattokinase, and I just didn't have a good feel for it. What are they really doing? I tried this on several, maybe 30 well patients or stable patients, shall we say. And I said, let's just try this and take it in graduated amounts, and they all came back, and they didn't come back fast enough actually. But as they came back, they were not happy. They said, what have you done? I was doing okay. I am miserable right now. And lo and behold, when I examined them, their livers had enlarged and their spleens had enlarged. Ergo, we have released babesia from the biofilm. Babesia lives in the biofilm, not just in the red cell where it's supposed to be, but it lives in the biofilm. So lesson learned. So nobody gets out of our clinic without biofilm treatment. And seriously, if we're going to treat babesia, we have to use biofilm. It's just unconscionable for us not to do it. If you want to sell this disease and scare the hell out of people, just say it makes you old. It does age you. It really does. Well, think about it. Who's going to age faster? The person that's got everything in metabolic balance and good tone, eats right, or the person that's absolutely racked with chronic inflammation? Who do you think is going to get older quicker? Whose bones are going to deteriorate and start to break down? So she's aged in front of us here. So we talk about chronic oxidative stress. This is another word for inflammation. We have chronic inflammation. That's the problem. Inflammation is a good thing. Chronic inflammation is not. It'll start to break down tissues. It creates all sorts of damage, breakdown, deterioration of critical cells, and also does other things. It tends to spin down certain key elements that are important for metabolism, like ferritin and carnitine, and certainly affects the hormones and so forth and so on. So it's fundamentally what's going on. It's what we try to arrest. We can't really treat people who are in the throes of an inflammatory storm. At least we want to get the needle as close to neutral as we can. So in summary, this infection complex is characterized by multi-compartmental neuropathology, multisystemic involvement, immune evasion, exhaustion, and immunosuppression, biofilm formation. Lipoprotein is what your Herxheimer is, and cause for the exaggerated inflammatory effect, and then chronic oxidative stress. So this is our pet peeve about listening to the patient. Unless I missed somewhere, I wasn't a real good medical student. I missed some class sometimes, but I must have missed a class where they said it was okay to be rude to the patient, or that you didn't have to listen to the patient. I missed those. And that's what's happening today. And you can learn so much just by being patient and trying to understand the picture the patient is trying to draw. And they all have different ENSELs, and they all have different platforms and so forth. It's your job to try to understand what the patient is trying to say to you. The patient's frightened, the patient's confused, the patient's anxious. You're going to leave real soon and walk out of the room. They won't be able to tell you what they need to tell you. So that's your job. So we just don't spend enough time. These are follow-up patients, just not enough time. So we had to get rid of insurance, unfortunately, because they're just driving the institution and of the profession of medicine, and so unfortunately we had to get rid of that. And so there are lots of things we have to understand. So this disease, in a way, makes better doctors. It really does. It gets back to the foundation and principles. You don't have to be an expert in everything, but you have to be competent in so many areas that you weren't trained in necessarily. So you have to understand about pain management. You have to understand about pharmacokinetics. Some of these things were easier for me because I'm an infectious disease background. You have to, nutrition is obviously very important. If I knew, and I have a lot to learn, but if I knew now, the nutrition now that I do know now, that in the day when I was treating HIV/AIDS, I would have been a much better doctor because I've learned so much about nutrition. There's so much more to learn. You have to know about neuroendocrine issues, how to manage those. We manage most of those ourselves. You have to take care of seizures, know how to do that, vascular health. You have to know how to put people to sleep in a physiologic and beneficial way. You have to manage psychiatric episodes. If we do have a friendly psychiatrist on board, we work with any specialist. We try to make friends all the time. But you know, if they don't want to be friends, then we do it ourselves. So gut health and understanding oxidative stress and the methylation pathways, doing the genetic studies, and then just understanding what your target is and constantly refining it. Okay, so Willie Sutton, nobody knows Willie Sutton, but he was a character in the US. He was a bank robber. He broke out of jail actually 4 times. And finally he went over and worked for the FBI and helped the FBI, taught the FBI how to prevent bank robberies. And so one of the reporters, he's quite a character, so the reporter asked him, "Willie, why do you rob banks?" And Willie said, "Because that's where the money is." And that is now known as Sutton's Law. So why does Jemsek JSC study the brain? Because, okay, so when we see a new patient, it's important to categorize and organize. So we go through major categories. There's a number of other review systems. The doctors in the room know this, that are another 15 or 20. But I break it down into this. I've been doing this for years. So I want to know how this person is doing in terms of cognitive, limbic irritability, dysautonomic features, modernized multiplex, which is stabbing, paresthesias, or motor damage, B symptoms, which is joint and muscle, and energy level. So we rate our patients and we put them on a scale, and this helps us. And it's awfully good if the spouse or friend is in the room to kind of balance the number, because looking from inside out with this illness is very tough. So we go through, the first thing that falls away in terms of chronic encephalopathy is multitasking. Okay, no multitasking. So you're having to take lists everywhere, you can't remember why you walked in the room, you can't make decisions, you can't remember what you just read, you can't find the doorknob sometimes. And so we need to know, we need to understand as we go through this, what the impact is. We also know that it's going to be modified if we repair sleep and get rid of pain. So if we get rid of those stressors, as I'll show, the cognitive function is going to improve, and that's what really we want to know. And look at it, the pretty colors our brains are. That's amazing. So real quickly, we have our frontal lobe, which has a lot to do with personality, impulse control, parietal, informational processing, temporal's memory, also has to do with certain speech and auditory processing. Occipital lobe, very interesting. This is our movie screen in the back of the brain that's funneled by the eyes. So you see visual snow, or I've had patients see kaleidoscopes, and and convergence is really a brainstem thing where you can't really focus. But anyway, you have to think of the brain in terms of rather than the organs sometimes. And so limbic irritability, the bottom of the brain is white matter, and this is what we call the limbic. This is where the disease hits the hardest. So this is why people, and it affects mood, and it affects, everything goes through there. It affects the way you process auditory and visual stimuli. It's the way you feel your body. Everything goes through there. And it's why some of the folks get a little bit irritable when they have their brain inflamed. This is the limbic system, which is beautiful. Here's our brainstem up to the midbrain. Here's our amygdala, which is the devil gland. That's the fight or flight, anger. Okay, it's connected to the hippocampus, which is very important memory, both long-term and short-term. Cingulate gyrus, I think, is important for processing information, and it's right under the cortex, so there's lots of connections there. And here we have our olfactory lobes going back to the brain, and so this is what we really look at. And there are limbic systems, or symptoms that we feel are very important characteristics, such as light sensitivity, noise sensitivity. We'll get into that a little bit, well, actually next. So one thing to understand about this is when the brain is going, things are going crazy, is that this brain doesn't think. It does not think. And here we have our pituitary. I'm going to move ahead. Thalamus, my favorite gland, just connects with everything. It's our sensory integrative center. It networks with everything, and it's almost always inflamed and causing altered perception. It's a relay station. It does cause the phonophobia and photophobia. And here we have our amygdala and hippocampus again. I just put this in because this is the largest white matter. The corpus callosum connects the brain. And let me go back here. Well, I'll just stick here. The amygdala, again, is the devil gland, controls our emotions, aggression, sleep regulation, lots of things that can go wrong in a very basic way. And I'm moving a little faster here. Mammillary bodies are very important as far as connectors between the hippocampus and the thalamus. And the circuit of Pepez was, in the 30s, was thought to be the source of mood. Now it's thought to be more a source of memory. So memory, short-term memory, has a lot of moving parts. With the circuit, it goes something like this through the hippocampus, hypothalamus, cingulate gyrus is very important. And it's thought to be more of a memory center. But Pepez and then future neuroscientists and neuroanatomists constantly trying to find out where is the mood of the brain and where does it exist. And short-term memory, or memory, has a lot of moving parts. So obviously repetition leads to long-term memory, very strong stimulus, something that really, really makes an impression. will more likely embed as a long-term impression. We have working memory, which is the stuff we keep in the queue and then forget about. And short-term memory is much more likely to go away and stay away in this disease than long-term memory. And whoops, oh, wait. All right, so the limbic system is the center of the storm, and here's some of the things that happen. Wait a minute, sorry. All right, so we have startle reflex, unprovoked crying and giggling, which are gelastic seizures, personality changes, rage, paranoia, hypervigilance, all these psych symptoms, pains, cravings, tremor, bruxism, vibrations, internal vibrations, feel like the body's shaking. And I call this the Komodo Syndrome because this is the biggest reptile I could think of, and it's a reptilian brain. So when the limbic system is inflamed, the clinical picture may be characterized by marked neuropsychic instability, intolerance of sensory input, and inability to interact with one's environment. And that is true. That is, oh. Yep. She's been a bad little girl. Okay, we're going to move quickly through the rest of this. Dysautonomia, very important. We have a nervous system, very important nervous system, yin and yang, sympathetic, parasympathetic, basically fibers go everywhere. This is sympathetic cervical ganglia, parasympathetic, so this is dilates, this is fear, fight or flight, and this is rest and digest. So we get POTS, NMH, lose your blood pressure, tachycardia, dysregulation of your temperature, nausea, unexplained nausea, air hunger, alternate flushing and chills, stomach bloats, voltage to the stomach slows down, blood pressure may go all over the place, you're sensitive to barometric change, to weather change, regional pain, Raynaud's phenomenon, and power down atonic seizures. So the autonomic nervous system is invariably involved here. We measure that. Modernized smoplex, just one slide. This is basically your peripheral nerves. If it's a sensory nerve and it's inflamed, it's going to be numb or burning and unpleasant. And if it's motor, it's going to involve muscle weakness and, in the worst case, atrophy. And finally, we have B symptoms. Not finally, but the next to last. We have B symptoms. How much joint pain do you have? Is that a major part? It's not always a major part of our patients, but it can be. And we get frank arthritis, of course. And then fatigue, which is a combination of many things. Oxidative stress, the mitochondrial damage. Everything's powered down. So the mitochondria just aren't jacked up enough. They don't have the voltage difference to provide energy, not making enough ATP. There's substrate deficiency. This disease sort of, if you run a platform or a scaffold, it's like it takes one piece away at a time, and pretty soon you compensate, you can't support yourself. You know, all these functions are taken away from you. The last two slides. I just want to mention what an EM rash is because everybody talks about that, and I wanted to shed some insight on what it is. Important to understand, EM rash, erythema migrans, is nothing more than an expanding rash of multiple morphologies, 2 centimeters expanding over a period of several days, painless, non-pruritic, and may or may not be a recognized bite there. The classic bullseye is the rash with a central clearing, but the classic bullseye is only present in a minority of cases. Now, this was interesting to me, and Judy would like this. And Salazar did a study in 2003 where he took EM rashes and he did a blister analysis. He put a suction cup up and caused a blister, and then he woke up. Okay, Alan, you'll get your turn. So he took the cell, he did cytology, and it was very interesting because he had, guess what he found in there? Now this is an EM, which is, everybody says, oh, you get a bite, you get your first bite, and then you get an EM, and then you get sick. Poppycock. It's not your first bite, it's an activation that occurs in a day or two. That's an amnestic response, immunologically. You know, a primary response takes a few days, a week at least. And he found memory cells. What are memory cells doing in there? In his abstract, he said they were cycling very fast through there. Poppycock. This is a memory cell. It sees the spirochete. It remembers the spirochete. You have a clone of cells, T cells, that were armed against the spirochete. When you get another challenge, here comes the inflammatory reaction. So to me, this means that when you get an EM, it's not your first bite. It's not your first rodeo, okay? You have the spirochete in your body. You can see bullseye rashes during therapy that come out. You can see it without therapy occurring spontaneously. You can see multiple rashes. So that's a huge fallacy in terms of what it means. So a lot of my patients are very inspiring to me because they have such determination, and so they give up so much and they trust so much, and I think that's a wonderful thing, and it's very important if you're the patient to have hope and determination. Now, this is our break. I did provide a handout, right? So a few years ago, I wrote to the Connecticut Attorney General outlining, along with P.J. Langhoff, our concerns about the IDSA, and I detailed with P.J. what happens if we do nothing and what happens if, who's going to benefit from this. And so it's about a 3-page handout, what I think you'll find interesting about the collusion that was going on then and continues. And the sad thing is not much has changed, not much at all. Thank you.